Welcome to Q&A with Prof. A. This is the Ibato kay Doc Bato educational series for medical students and residents. Our question for today is, what are the top 5 habits in fluid and electrolyte therapy in children that we do for no reason? The answer is, it's the default fluid prescription of parenteral maintenance. The first habit is, maintenance water therapy is given parenterally. Let us review what is maintenance water requirement. It is the continued daily losses of water and electrolytes occurring via physiologic processes which normally preserve homeostasis. These losses come from urine, sweat, stool, and respiration. Let me emphasize, it's physiologic and it is normal. Is there any clear and present danger if a patient receives IV maintenance water prescription? In most cases, routine maintenance can be met enterally. Purely routine and parenteral or IV are relatively unusual. The provision of IV fluids and electrolytes to patients who cannot meet their needs enterally yet are otherwise healthy, such that indications are very rare. Giving it intravenously may be unphysiologic and even unethical. There are reports that it will lead to iatrogenic hyponatremia, which can be severe and have catastrophic complications. Habit number 2. Patients on NPO are placed on IV maintenance. Why do we place patients on NPO? It is usually for sedation prior to a procedure or pre-operative. We all know that anesthesia or sedatives reduce or eliminate airway protective reflexes, such that it will reduce the risk of aspiration by decreasing the gastric volume and pH. What concerns are anticipated if children are placed on NPO, especially infants and young children? Theoretically, we expect hypoglycemia, hypovolemia, ketosis, hunger, and dehydration. But if you review their normal physiology, at what age can the child achieve full maturation of glucose and water metabolism? The competence of the liver for gluconeogenesis is achieved by 12 months of age, while the maturation of the concentrating ability and the sodium handling of the kidneys occur at 6 to 12 months of age. This means that as early as 6 months of age, infants can tolerate periods of NPO without the risk of developing hypovolemia and even hypoglycemia. In fact, some anesthesiologists will actually recommend giving them hard candy, like a lollipop, to suck on until even induction, without the fear of them aspirating. Placing them on IV maintenance while on NPO for a procedure is truly unnecessary. This holds true for older children and adults. NPO prior to surgery is different. In the first place, these patients will require more than maintenance because of the anticipated and even ongoing significant isotonic and insensible losses like blood and GI secretions that will be incurred during the surgery. Definitely, putting them on just on IV maintenance rate is wrong. What do the current guidelines say about NPO? If a patient took solids, it should be 6 hours prior to a procedure, while for clear liquids, it is 1 hour prior to procedure. For infants less than 6 months, breast milk should be given 3 hours prior to procedure, while formula fed, it's around 4 hours. Looking at all the current guidelines on NPO, there is really no mention that you should put a patient or a child or an infant on IV maintenance while on NPO. Habit number 3. Patients with poor oral intake who are anorexic or vomiting are placed on IV maintenance. Remember, when a child has poor oral intake or poor appetite, he is actually sick. So he is not normal. And I don't think maintenance fluid therapy, which is for normal physiologic processes, should be given to him. What hormonal systems are affected if a patient has the above GI symptoms? You will be dehydrated because you have decreased fluid intake. So I don't think maintenance will be enough. There are certain hormones like your B-type natriuretic peptide which exert anorectic effects. And being a natriuretic, you lose a lot of sodium and water. And then I think maintenance would not be exact. You also have ADH, or antidiuretic hormone, which is released by thirst, nausea, vomiting, and pain. So patients who present with such symptoms, they may require more than maintenance. Habit number 4. Patients who are tachypnic or with altered mental states are placed on IV maintenance. Are there any significant water loss among patients with pulmonary and neurologic disorders? Looking at the table, there are increased losses with tachypnea and with high-grade fever. While on the other hand, there are decreased losses if you use humidified air, there is decreased activity, there is hypothermia, and there is sedation. So I don't think putting them on maintenance IV is exact or proper. Habit number 5. D5-IMB and D5-NM are balanced solutions commonly used for IV maintenance. How do you classify the different commercially available parenteral solutions? We describe them as balanced, meaning most electrolytes are in the solution, or tonicity, the amount of sodium ions in the solution, or osmolarity, the amount of all the osmoles, including sodium, in the solution. Or is it for resuscitation, which is the restoration of your intravascular volume space? Or is it for rehydration, which is your restoration of your intracellular fluid space? The habit of using D5-IMB and D5-NM as hypotonic balanced solutions for IV maintenance comes from the idea that we need a certain amount of sodium per day, and it depends on the age group. However, remember, this is for normal physiologic processes and not to be used for patients who are sick, who are losing a lot of sodium and water, and should not be placed on IV maintenance depending on the sodium requirement. For more high-yield topics in pediatric nephrology, don't forget to click the subscribe button.